retainers you use. Everybody can say a low voltage BFI. Now that doesn't earn you marks, but it's about what makes that case difficult to retain and how you might change your treatment mechanics to improve retention at the end of the plan. Again, it's 4 cases, exactly the same, so it will feel exactly like the preparation for the diagnostics. 4 cases, 15 minutes pull-up and a 15-minute viva, and exactly the same again, 2 examiners, but only 1 will ask you the question. So again, for the standardisation and to make that flow, just 1 examiner moving you all the way through it. So it will look and feel like a diagnostic case. Okay, so in terms of your preparation, you prepare the same way. You will be given a set of start records. Now they might not have absolutely everything that you would have in your diagnostic case, but it's just to give you a flavour of the case, okay? And to allow you to look at some of the more significant features of it, but that's not the key area, so don't focus on that bit too long. You're given a 3-line summary. So if somebody says, give me a summary of this case, you can just read it off the paper, okay? Your summary is there. So the diagnostic records will be slightly compressed, and the summary will be there for you. You'll then have mid-treatment records. Normally 1 set of records. Sometimes the odd thing is missing. You might not have a mid-treatment KEF, you might not have a mid-treatment SMILE, and you might say to your examiner, actually it would be nice at this stage, I'd like to see what KEF the metric change is, and often the examiner will say the lower incisors have moved, or the patient's not grown in favour. Okay, so we'll try and give you that information. But most of the information you need is there to make the next decision. So intraoral pictures, we've expanded the pictures to make them much bigger and easier to see, so you can pick out the mechanics that are ongoing at the moment. You'll have a little summary of where that patient is now. Now they may have only just had their braces fitted, they might have been in treatment 6 weeks. And you'll see the appliances at 6 weeks. They may have been in treatment 15 months. So there's a big variety of cases in this bank where the cases are at all different stages of treatment. Okay? So don't look at it and go, well, so you just started, or this treatment's nearly finished. They will all have interesting things happening with them usually, but not all of them. Some might be progressing absolutely fine, but they're early on in treatment, and they still need some thought about how you will use your artery sequence, etc. And there is a treatment plan, and it's very simple. It normally says retention. In the middle it says what the patient's aims will be, and at the start what extraction pattern, if anything, that has been chosen for this patient. So you'll have a basic treatment plan of what that orthodontist thought was the requirements or what aims they had. So it might be their aim to treatment in class 1, and you look at their extraction pattern and go, actually that wasn't achievable. That will be one of our questions. Do you think that the aims of the orthodontist at the start are still achievable? And in some cases you'll go, yeah, I think that's manageable. And others you'll go, good chance. Some real issues with this case. So you'll be given the treatment plan. So this is not about your planning, this is not about your diagnosis, other than picking up the major features, but it is about, we might ask you, would you have done that treatment plan? And you might say, oh, no, I'd have done the twin block, I wouldn't have taken the treatment out, but we will leave it there, because this patient's sitting in your chair now. So you think of this patient as a transfer case. They've arrived in your surgery today with a letter from the orthodontist with this information. Tell me what this case looks like now, how you take it forward. Don't take a step back and go, no, I would have taken. That doesn't matter. You can't put teeth back in. They may not have been the teeth that you've chosen, and actually, they may have treated it non-extraction and you want to take teeth out, that's okay. But this is a patient in transfer for you to make decisions from now, from this mid-treatment set of focus. Is that all clear? Yeah? Good. There'll be a range of cases. So people just asked me before, will there be a Damon case? Will there be an Invisalign case? There could be any type of appliance system in there. As a trained orthodontist, the orthodontic curriculum includes all of those appliance systems. Now you may not be experienced with them. You may not be experienced with a self-ligating brachial. That's okay. You just say, well, I've never used that appliance system before. In my hands, I would be uncomfortable taking the case forward with that appliance system, and I think I would probably want to change my brackets. That's fine. Your examiner will not say, do you not think you can carry on with those? Or if they do, just say no. So we all have our individual skills. So if it's an Invisalign case, probably would continue it, or I'd say to the patient, okay, you've got your aligners, let's finish on, and I'll put some things on and finish it. But in a certain case it might work, but there might be an Invisalign case, there might be ceramic brackets, there might be mechanics that you've never seen before, but you should still have an idea of what those mechanics are trying to achieve. But it's okay to remove them if they're not working or you're not happy. Alright. So, it's a transfer case. We want to know where they're up to now. So, what can you see today? What happened for this patient? What mechanics have they currently got running? What do you think they're trying to achieve? Are they making good progress? This patient's been in treatment for 18 months with a twin block, and they've still got 7mm overjet. Do you think that's good progress? What would you expect to see at this stage? So look at how long they've been in treatment, and look at where the teeth are, and pick out why that might be. Might be the patient's been knocking on brackets. Are there any clues to that? Might be that they've only just picked the sevens. That's why they've dropped to around 9 rather than maybe think it's taken square one. So just have a look for clues of why that patient may be at that stage. Because we might say, why do you think they've not progressed? There's lots of reasons why treatment doesn't progress. We can say they've got breakages, they've got deep bite there, hasn't been blocked open, the patient may have not turned up for appointments, and maybe expect this treatment to be a little bit further on. So it's okay to criticise where it's at, but think about the reasons that that might be the case. So does a plan look like it's working? Are things going the way that the orthodontist has sent the patient to would like? And what are the current mechanics? So try and look at all the different mechanics that are working. If you don't pick them out, we will. So if there's certain things that we've discussed in our examiners meeting that we think you should be picking up, they put power chain on a light arch wire and the teeth have rotated off. You know, they've overpowered their lace back and the canine's now tipped and some roller coastering effect. There's all these little things that we want you to pick up because we all have mechanics, bad things that we do from time to time. So we try and pick cases that may have things that may be not ideal. How is the anchorage being managed at the moment? How will you manage the anchorage going forward will be the key question. Remember we said retention is about the retention challenges. They've got a midline diastema. That's a retention issue. How are you going to deal with that? I'm going to close it early. I'm going to look at the Freedom attachment. You know, Edwards, good paper Edwards? No, 2 years ago, but I might put a bonded retainer because of that. Not just I'm going to use bonded retainers. We talked before about an active retainer. There's a deep bite. You could use an active retainer with an active bite plane, with a Hawley on. The patient side Hawleys, no. Would you use it? No, I'd use a VFR. As long as you justify why you use something, that's absolutely fine. Think about the rotations. I would overcorrect them from an early stage, again in treatment, and hold things nice and steady. The patient has a slight class 3 tendency. I'd be worried maybe that they're going to grow a little, so I'd be monitoring that post-treatment. So growth could upset our result. Not getting good into digitation, having lateral open bites could affect our result. So it is the retention challenges, not what retainers you can use. It's okay to add an use VFR and justify it. That's not where you get your major marks. Because everybody can say upper and lower bonding and VFR. That's not going to pass you. Understanding where the retention issues are is where the marks will be. Okay, so again, going to the Royal College website, we have a test case up there, so please use it for practice to have a look at and give you an idea of the format that you're expected to see. So I'm only going to flick it up on screen. If you click onto that, I'm going to whiz through this quickly because I don't want you to see too much of it, but you can see the start records there at the beginning. It's minimal start records, the summary. You've got the KEF values at the start, you've got a treatment plan, and then you've got a patient who's got some appliances on, how long they've been in treatment, and what arch wires are in there. So it'll normally tell you, patient is in 016 up at night eye, 014 low night eye, been in treatment 6 months. Okay, so I won't leave it up there too much. That case is available for you to download, but I would suggest you use it as a practice. Don't just sit there looking at it. See it for the first time, fresh, look at it for 15 minutes, and test each other. Okay? Probably not somebody who's about to sit there and once they've heard your treatment plan, they go, So, we have 3 domains, just like we do for the diagnostic section, and this is the slide that you should all take a picture of, because these are the questions you're going to be asked. It doesn't matter that you know the question, because the answer is different for every single case. Okay, you can know the questions that we will start each section with. So you will get asked these questions on every mechanics case. And knowing that, that means you can go into the exam thinking, right, what are the challenges in this case? You'll be ready. Yeah, because it's the same for everybody. It's not giving you the answers, these are our questions. So in terms of knowing those questions, you can then start to prepare a structured way in which you will present the case to us. Okay? So sometimes some people ask for a quick summary. If they do, we've got the summary already written on the page. But then we'll say, what were the challenges at the start? That's just to settle you in and just to pick up the key features of that case that made it difficult to treat at the start. Because we might bring that back in later. What was a severe class 2, severe ground? Well, let's try to treat that non-extraction. I think but at the start it was severe. Just so that you've got something to refer back to. Then to describe the mechanics, describe what you see. We'll take you through maybe the lower arch and the upper arch, point out things if you don't point it out yourself. The more you point out yourself, the less I talk, the more marks you have. Okay. How are things progressing? Yeah, it's going right. It's 9 months into treatment. They've got a twin block in. Twin blocks reducing Overjet from 11 down to 7. I think that's probably quite good, but I can't see any lateral open fights. So maybe they're not wearing it quite as well as they could do. The patient was a little bit older, they were 14 to start, so I'm not sure how much growth we've got. Yeah, we'll get back to the start records. The next phase is what are the anchorage challenges at this stage in all 3 planes of stage? Not at the start. Now this patient's sitting in your chair. Yeah, they started with an 8mm overjet, they now have a 10mm overjet. Okay? So look at AP, transverse, vertical. How would you manage those anchorage challenges going forward? So we now start to think about mechanics you're going to go put in place to manage the anchorage. So there's a significant AP anchorage issue here. They've tried to treat it non-extraction, but I think I'm going to have to use an extraction-based treatment plan for the next phase to be able to resolve the overjet, or we've just about got enough up there, but I think I'd like some additional anchorage support with the TPA or the TAL or whatever I'm using. You justify it, that's fine. And then the key question we say, this is your case now, it's their first visit in the chair. So don't say, oh, I'm not sure, what are you doing today? So if you start to procrastinate, you try and not answer us, we will say they're sitting in your chair. They've got a TPA, they've got Damon on, they've got this twin block running at the same time. What are you going to do? So I'd stop the twin block because it's obviously not working. I'm really happy with Damon because I've used it a few times, but I don't have it in my surgery, so if I have to replace brackets, the in-out on the Damon is different from my own implant, so I might have to do some finishing out. Straight away, I'm understanding that you're a clinician that treats lots of patients, and it's quite clear to us that people that have had a broad clinical experience, and those that don't understand the differences between prescriptions and practice. So how would you progress from this point? Are you going to stick or twist? Yeah? You're in the casino, you can go for that extra card or you're going to go burst. So are you happy with the plan that the orthodontist has provided so far? We've got plenty of cases over the last few diets where it's like, yeah, it's going pretty much okay. I think my anchorage is still an issue, but I'm happy with their start plan and I'm going to carry on down that line, but I need to be careful about these 2 or 3 things. Or, no, I'm really unhappy with this plan. I think I'd take those mechanics off. I'd be much more careful bringing my canine down because this patient doesn't have much overbite and they plug the arch wire into this canine that's up here. That's going to intrude and flare my incisors forwards. Or they put power chain on my lower incisors and they're severely rotated, so I'd get rid of those mechanics, get my lower arch nicely aligned and only start to use power chain and bigger arch. So you can criticise and change mechanics to what you think is going to move the case forward. And then we talk about retention challenges. So, this is just a basic, and some of you do this really well and some not so well. So if you're talking about the challenges in a case, or the problem list of a case, always think systematically and start with pathology. Pathology is always the biggest challenge. An impacted tooth, a cyst on a tooth, traumatized tooth, all of those things will change everything else about the treatment before you think of skeletal, dental, and soft tissue. Because if a cyst is grossly carious with a periapical area, you need to decide on what to do with that first before you decide on the rest of your occlusion. So, if you always have pathology, skeletal, dental, soft tissue, you'll systematically go through that rather than hopping about to get people, what are the problems? The really crowded tooth there, the overjet, the vertical facial line, and it's not structured, and you miss things out. So pathology, there's an impacted upper left rib with root resorption on the tooth. Skeletal, there's a significant class 2 element with vertical and transverse issues. Dental, there is severe upper and lower arch crowding with a centerline shift. Soft tissue, there's a thin gingival biotype and a thick midline free. Brilliant, nice and systematic. Challenges or problems, always nicely in that level. And then you're not going to forget anything. And even if you've forgotten one thing, but you've got 1 or 2 things in each of those, it feels structured to the examiner as a rounded review of the case. Yeah, does that all make sense? Who does it that way already? Maybe one? It's the way I'll teach my registrars. It's a really good way. 2 or 3 people did it this week, so I was quite impressed. Guess how you prepare for these? Practice, practice, practice. These cases are easier for you to get because you've got cases that your colleagues have never seen. And they've got cases you've never seen. And hopefully you've got photographs early on in treatment. Okay? So get your records together, build a small library, build a group view, and test each other. These are much easier cases for you to present. Find the really nasty ones. Yeah? The ones where you've only just bonded up, it's a really difficult one. Yeah, you've got a plan on the reframing. It'll be fun. You will learn from their responses, and you'll learn from their cases. So try and get together as a group. My registrars often form a WhatsApp group and they meet up online. It's so much easier now with virtual technology to show cases online to each other, share your information, share it for 15 minutes, and then ask those questions. I've given you the questions already. Yeah? So you can now rival your colleagues. And that prepares you to pace work through it. So time testing is really important. But it's no good if all those cases are just class 2 division 1 or class 1 cases. So try and find a range of cases between you that will help everybody. I can't state enough how helping each other gets you all much better in terms of what to do. General tips, we want you to pass. Okay, we would like you to pass. We understand that you are nervous, so just calm, relax, smile. We will be there. Worry, you're okay. Got water down, need a glass of water. People sometimes go, just a glass of water, that's fine. You're there to try and help. Does me do 20 minutes, there's a customer, slow down. So if somebody asks you to slow down, they're not marking you badly. They can't hear what you're saying, okay? You may have an accent there. Speaking slowly and firmly to a loud enough level that we can. You don't need to say it's a class 2 and shout at the examiner because everybody else in the room can then hear it. But we might say, just speak up a little bit, I can't hear. Because we're sat across the desk. It's a room like this with 8 candidates going at the same time. I can't really hear what's going on. I'm focused on you. That's really. But what was that? Okay, so speak at a level that can be heard. Again, when you're doing your own vivas between you in English, not in Arabic, in English. You're not going to get better at speaking unless you use English. You need to be able to hear. You need to do it at a nice, steady pace that comes through. You can hear those words. If you machine gun your words at us, often you're saying all the right things, but we can't hear it. This is not a problem here. It's a problem across the world. My registrars, when I see they've got so much information they're desperate to give me because it's all there on paper, and it's just rattling out of their head so quickly that I can't hear it. I'm missing elements. And sometimes, you know, if you don't slow down, we're not marking on things you've said. Does that make sense? Again, practice makes perfect. This is quite a tip, and it surprises me that people don't understand this concept. So if somebody says to me, right, there's a 2 mm centerline discrepancy in the arch on the right, I'm going to take out the lower left 5 and I'm going to correct that and keep my centerline. There's crowding on the right hand side. And I say to them, right, are you sure that at the end of treatment your lower centerline is going to be correct? Yes. So well, I disagree with you there, because you told me you're resolving your crowding on the right side by moving your centerline to the left into the space. So if you take a tooth out on the left, you're going to end up now with a 2 mm centerline discrepancy on the left hand side. Do you think that's fine? Yes, yes, it'll be fine. Well, I've tried to help you. I've said I disagree with you. That normally means, oh, actually, yeah, that might be a problem. Pick up on it. We are trying to help you. Yeah? Examiners, we don't now ask the question, are you sure? Because that unsettles candidates. I want to take out upper 4s and lower 5s. Are you sure? That's not helpful. So the examiners won't ask that question. Okay. You want to take out upper 4s, lower 5s. Tell me why you want to take those teeth out. What's the justification for it? We might go, given the fact that, you know, this is a class 3 case and it's not crowded in the upper arch, can you think of a better extraction plan on the upper arch? Are you trying to steer you that way if you're generally doing well? Maybe upper 5s might be slightly better here because I have no crowding and I want to keep my maybe it's open forward, so yeah, maybe 5s. Make that change early enough. You might not score high marks, but we may still see the same. It's a bit late on the treatment if you take the 4 teeth out and you're galloping along with mechanics. This case is going bad. Don't sit and say nothing. I had a couple of candidates this week and I asked a question though. So I asked the question again, and then I simplified the question, and I went down to a yes/no answer, and I still had. I wasn't sure, did they not understand me? So again, at the end of the Viva, I turned to my colleague and said, I asked the same questions that I did to the last one. Did I say something wrong? No. So don't say nothing. Okay, if you didn't hear us or you didn't clock it, it's okay to say, oh, sorry, I didn't hear that. Please don't go, what? We've got a couple of candidates that like to lean forward and go, what? Sorry, I didn't understand that. Okay, there's nothing annoys me examiner more than somebody who's arrogant or somebody who goes, what? That's impolite, that's not how you treat a colleague. When you come through and sit down and I don't quite hear, I don't go, what? So, sorry, could you say that again? I didn't quite catch it. So, behaviour. Don't waste time on the normal, particularly on the extra-oral cases as we move through. Say, you know, it's an OPG, everything's normal. The main features of note are the impacted canine here. I've used this radiograph to look at the position of it, or CBCT, and I've had a look at that. There isn't a CBCT, but I think I would like one here. Don't say this is acceptable, the condyles, blah, blah. We don't want to know normal, okay? We've got 15 minutes. We're here to pick the problems with this case. Now, the examiner wants you to pick up something. They'll go, what about the condyles? What did you think of those? What about any other irritant teeth? Okay, just say. So 7 to 7, I'm happy with the root morphology, apart from the upper left 2, which is a little bit short, a little bit, but otherwise the main features of note are this. And straight away I know you're picking out the things that are going to make that case that's more difficult. Do what you do. Yes, if you don't do Damon and the Damon client comes in, swap to your bracket, you can be better managing it. You know, if you're not comfortable doing a 6s and 4s case, just go, I understand there are probably other options. I've heard you can do 6s and 4s for this, but I would feel not very confident with my management. So it's slow for me, and I think my clients would work better. Okay, so try not to do something for the first time. The amount of candidates that say, oh yes, I'm going to do TADs here, there, and everywhere. You ever done the TAD? What's the best place? So try and stick to things that you know about. If it's not something you do, but you have a good grasp of the mechanics for it, that's okay. I've never done this personally, but I understand the process of maybe some intrusion for molars, with some TADs posteriorly. I haven't got that experience, so I would use my mechanics, but I know you can probably put some TADs in, have a TPA, and intrude the molars, and Don't be afraid to ask for clarification, but please don't do it for every question. Again, there's nothing more annoying than every time we ask a question, you ask for clarification because we've doubled the length of the questioning and now we're not progressing to give you further information. If you know references, give them. And a little bit about that paper. That will mark you up the scale. You can't go to the top of the scale without reference. You do a really good Bible. There were lots of people this week who scored 4s, which is gets everything. To get 5, it's gets everything, supports it all with the literature. Now, if you do really well, we'll probably ask you about the paper, but it was quite telling this week. 2 candidates gave me papers and knew a bit about it. Just mentioning the name and the dates, not enough, just 2 candidates. There were very few really high marks. What people scored got most of the things. But when I asked them for a reference, they would go, yes, I know there's a reference about that, but I don't know anything about it. So think about the literature that might support. If you don't know, say no. And we'll say, don't worry, let's move on. We haven't got time to waste in things that you don't know. We're trying to find out what you do know. Okay, so just sorry, I don't know that. So if I say, what about the references for the effects of Twitter? You go, I know there are some, but I'm sorry, I don't know them. That's fine. Don't worry, we'll move on. Just a bit about professionalism. Colin's already sort of alluded to some of this. Your professionalism is how you behave and how we see you. Today is a casual day. I take my tie off later. So I'm feeling quite relaxed with you guys. You're friendly. But in the exam, it is a more formal experience and it is a high-level professional exam. Okay? This is a worldwide recognised qualification. You are highly professional, highly trained people. We expect you to behave in that way. Don't want the best suit possible with a bow tie, you don't need to do that. But we do expect you to turn up in professional attire, as Colin's already said. You must treat our staff with professional behaviour. We will not tolerate bad behaviour towards the exam staff. Our exam runs like clockwork today. They do all the hard work in the back. Here at NGU we have local staff who speak Arabic, support our staff and let them get on with their job. For particular queries that you want to ask the lead examiner, if they're relevant, you will happily come and speak to you. If it's trite rubbish, you won't. We are busy people. We do not want to disturb all the other candidates. If you've got a genuine issue, we had somebody this week who felt ill. We are there to try and support you and move you away. But we have a responsibility to the person who's feeling ill. We also have a responsibility to all the other candidates so they're not disturbed by that as well. So please treat our staff with respect. You will be treated with the utmost respect and friendliness. We just want a bit of reciprocation. And any poor behaviour will be removed from the exam. You will be excluded from the system. We have had, particularly, I think a couple of dials ago, people arguing, being nasty towards the exam staff. That's just unacceptable in any realm. But in a high stakes exam, nervous or not, you do not treat our staff in that way. They are an extension of us as the lead exam team. We will frown upon that significantly. As we would as well, if anybody tries to collect or distribute anything towards the material we hold in the college, the security of that material is important for you guys to know that we've sat an exam that is secure, is set at a high level, and that you've had the same opportunity as everybody else. I hope you would all agree that's how the exam should be. It's rare that anything like that. So, should we have a quick look at a case? Would you like to see a mechanics case? I haven't given you all the information here. So another one of my cases. I haven't got final photos, but this one turned out well. But it doesn't look like it's going to turn out well. There's a 13-year-old girl, so this is your history at the start. She doesn't like her gap in teeth. She's got missing upper 2s and impacted upper 3. A lateral calf wasn't taken. Discuss that maybe a little bit. Plan was to close the upper space with extraction of the upper C, disguising the canines as lateral incisors. She's been in treatment for 9 months. She's in upper 1925 steel, upper and lower arch. Right? the face. She's a bit flat and a bit protrusive, but pretty much class 1-ish, maybe a little bit mark 2-ish on the chin. But nothing remarkable about her external features. Here's her occlusion. We've got a reasonable overbite, fairly normal overjet. The buccal segments are class 1. Okay, so straight away we're thinking we're going to close space in the upper arch, and our molars are class 1. That means we're bringing that buccal segment forwards, full unit if we're going to crack that. The lower arch is going to be treated on a non-extraction basis. The upper left canine's impacted. We can see the upper left 5 and lower left 5 just about to erupt. There's the upper left canine. It's in a moderate position. But recently, as he's gone, we're going to see if that tooth will erupt. And here she is at 9 months. So there's some worrying things going on here. So I'd expect a candidate to start looking. So if I say, what do you think about progress? Well, we're in 1925 steel. So for 9 months, in terms of the alignment of the teeth, the actual size of arch wire is quite good progress. We're into the working arch wire at this stage. But there are some things going on that may be slightly more problematic. There are some things I'm not so happy about. For example, here's the canine at the upper left. It's certainly improved, but no surgery has been done. Now, can you see the picture on the left? You can see the canine is just coming through. So you might want to be critical here and say, well, you know, we're 9 months in, we're in a working arch wire, we haven't got a canine as part of the appliance yet. I personally would have asked for that tooth to be exposed. The patient was already 13 years of age, and I'd probably want that tooth exposed earlier. I didn't. I was happy to wait for it to come down, and actually then the patient doesn't need surgery. So I might say, well, what's the advantage of leaving it? What's the disadvantage? Well, if it doesn't come through, now I'm 12 months in, and the tooth still isn't covered. So there's no right answer here. If you said I'd expose it early, that's just as valid. You know, I may have been in a situation where it didn't come through, and then the patient needed surgery, and I'm a bit in trouble. So there's no right answer. If you wanted to step in earlier, that would be fine, and your justification for that would be fine. Since progressing, what's a major issue that's a problem here? What would you pick out as the biggest worry? Anchorage, in particular, what do you see? There's another reason the overbite's shallow there. Have a look. Yes, you've got a lot of space still to close. There is a reduced overbite, but you've got props on there, so you can't really see how much the overbite is, but it was 50%. There are only small props at the back, so we've lost overbite a little bit, and we've lost AP. We're almost in an edge-to-edge position, so our anchorage now, that was a challenge at the start, is now much more challenging. Yeah, we're still planning to move that buccal segment a full unit forwards. How are we going to manage that? So, anterior screw. So I would say, I then start to question, is that a good place for the screw? If you've got it in the anterior region, how do you add mechanics from that screw to the posterior teeth that cheese wire through the gums? How stable do you think that's going to be? What would be the vertical change in having a screw high down to your molars at the back? So I want to know, if you're going to put a screw there, you know all the effects and the risks of replacing the screw. It's not a good place to put a screw to be coming forward. Are you going to use it indirectly or not? You can use it direct, that causes all sorts of vertical issues, depending on where you try and attach. So that's fine, it's not a wrong answer, but if you're going to use it, you better understand all the effects, where you're going to put it, the risks, and what you'd be looking out for. Because I know, I expect you to know as well. So don't use a mechanic if you don't understand the problems potentially. So again, so I use a TAD T-bar for the palate. So I put a TAD in the anterior palate with a bar fixed to the anterior teeth and supported with plaster. Colin's got a brilliant case where he use reversible headgear, yeah, in a 14-year-old, which you would look at and think, really? Somebody wants to wear reverse headgear? But the option he gave her was bridges or wear the headgear to give the anterior anchorage. And she wanted the headgear. She wore it brilliantly and got fantastic results. So there's no right answer here. Fine, you can use an anterior tab there, but you'll need two of them. You'll need to use them directly. If you use them indirectly, how will that work and how will you attach them? So by all means, use what you're comfortable with. You must understand this is mechanics exam. So if you use something you don't understand the effects on the appliances, that will be affected. So you have to understand all the problems with it. Okay, the lower arch is nicely aligned. We've got all the spaces pretty much closed. We've got a solid block in the lower arch, but that also means we've got no more retraction in the lower arch. So in terms of our AP, our lower isn't going to help us, but we've got a solid anchorage block that we could attach. Why is a bike propped open? Say again. Why is the bite block? Why have we got this blue bite block on? Look at the interdigitation of that case.
Maybe crossbite.
It's not a crossbite, it's the interdigitation. You can't slide teeth when they are locked into occlusion. Look at that sharp cruspal morphology. Without the bite block, the 4 is locked into class 1. It's never going to move. So we have to unlock the bite to be able to slide the teeth forwards. And that has a bit of a problem with our anterior anchorage, because we were gaining anchorage from the overbite, and now we've lost that anchorage anterior, which is why I'm at mentality bar. So there are some real anchorage issues to discuss in this case. I can't spend too long on it, but I just wanted to show the sort of things. I might point out the tube on the file and say, have you seen this before? No, I've never seen a tube. Why do you think the tube might be used? No friction, good rotation control, makes scalable, so I'm using a seat. Simple things like that. Yeah, so in the upper arch that is smart clip appliance. So I've used smart clip to reduce the friction, and I'm moving tooth by tooth to reduce the anchorage requirements. So again, all these little things to pick up. Now it doesn't matter that you don't know what that bracket is. That's a smart clip bracket I use a lot for individual sliding and for canine cases. So I might, and if you said, oh, it looks slightly different, but I'm not sure, is it self-ligating, or I'm not sure, I might tell you, well, it's a self-ligating bracket. Why do you think this person has used the self-ligating bracket? So don't worry, I don't expect you to. Quite a few people this week didn't know it was a Dana bracket, but they knew it was a self-ligating bracket. You lose marks if you don't know the brand. Okay? How would you retain this case? By the way, it finished fine. She's got positive overbite over there, all the spaces closed. Class 3 elastics, anterior T-bar was the mechanics that I used, and I had a really good patient. But it was a really difficult treatment. So if you said, I'm really unhappy with that, I don't think the anchorage is manageable here, I would much rather keep the space and move the canines distally and hold space for a lateral incisor. Okay, you've still got a heavy anchorage demand because you can't afford for your molars to come forwards. But maybe that anchorage is easier to manage than the anterior anchorage, because if you've never put an anterior tab in the palate, putting the tabs posteriorly is easier. And you could just put a tab, tie it to your falls, keep your molar segments nice and secure, and retract your canines. But it will be a full unit, class 2 canine movement. And then we would talk about moving your canine roots out of the way, maybe for implants, what space we would need for implants. If you're closing the space like me, what brackets are on there, what torque you might do, what other options there are for torque, how do you express torque more easily, what wires, what materials you might use. Yes? Or you might say, take 5s out. I'll close space in the upper, but I want teeth out in the lower arch to deepen my overbite. That's not wrong either. I might go back to the face and say, you know, part of the reason I'm trying to hold the upper incisors forwards is she's a little bit flat. So I might say, that's okay, what effects do you think that might have on the profile? I might say, she's a little bit flat, that might flatten her a bit more, but I'd still rather close the space and it will relieve my anchorage. Absolutely. That's just as correct answer as me trying to close the space in the upper. Speak up a bit. Again, you know, we're in a Viva here, I can't hear what you're saying. Yeah, that's what I'll be asking you. Yeah, you tell me. Because to get those mechanics working, I'm going to have to drop down to a smaller arch wire to use piggyback mechanics. It's difficult to use piggyback mechanics with a 1925 filling the slot, so that will be more difficult. I think we need to draw things to a close on this. You can ask me about the case afterwards, but it gives you a flavour of what's going on with the mechanics case. There is no right answer. Okay, there were lots of options there to move forward. Perfect. All good? All happy? Is it useful?